Dear committee members and dear audience, I would like to present my PhD thesis, which is Innovative Multimodal Imaging Techniques in Dermatology. My name is Noémi Varga. I'm a medical doctor and a second-year PhD student at the Department of Dermatology, Semmelweis University. My supervisors are Nóra and Marta Medvec. Our vision is to improve the survival of skin tumor patients, and in order to achieve this vision, our mission is to promote the implementation of novel imaging techniques in clinical practice. We have two projects. The first is a systematic review and meta-analysis, and the second one is a single-center prospective validation study. I would like to start with my first project, which is diagnostic accuracy of novel optical imaging techniques for melanoma detection. Malignant melanoma is a melanocytic tumor that is responsible for the most skin cancer-related death, with an estimated death rate of nearly 8,000 people every year. The main reason for low survival rate is delayed therapy, and that's why early diagnosis is crucial. So there is an unmet need to find new diagnostic techniques. Currently, dermoscopy is the used gold standard method for examining melanoma, but it has several drawbacks, such as it is examiner dependent and it has limited diagnostic reliability. Novel non-invasive optical diagnostic techniques use the light and the special properties of photon to obtain more detailed and higher resolution images of the skin. Therefore, we aim to compare the diagnostic accuracy of non-invasive optical imaging techniques for the detection of melanoma. This led us to our clinical question, which is the most accurate non-invasive optical diagnostic tool for the detection of melanoma. We use the PEERT framework, and here we plan to compare all the non-invasive optical diagnostic techniques to the reference standard histology, and after that we compare them with each other as well. Our hypothesis was that novel non-invasive optical diagnostic techniques have better diagnostic accuracy than conventional dermoscopy. Here you can see the search key which we used in 3 databases. And we started with more than 16,000 articles, and at the end we got 148 eligible full text. This slide presents the results of random effects diagnostic meta-analysis comparing the sensitivity and specificity of various optical imaging techniques used in melanoma diagnosis. The bivariate plot on the left displays the sensitivity versus 1- specificity for each method, with different colors indicating different techniques. This figure helps to visualize the diagnostic performance of each technique and the overlap between the techniques. The table on the right displays the detailed summary of the sensitivity and specificity results for the techniques, and the methods are ranked based on the sensitivity results. Based on the bivariate analysis, dermoscopy combined with artificial intelligence and reflectance confocal microscopy reached the highest sensitivity results. However, the specificity slightly varied. Multispectral imaging combined with artificial intelligence offered a balanced performance of high specificity and sensitivity alongside with dermoscopy and teledermoscopy. And out of these 6, multispectral imaging reached the lowest diagnostic accuracy results. In addition to the previously mentioned 6 methods, we also investigated 3 other optical imaging techniques, but due to the limited number of articles, they are presented on forest plots. Based on our statistical analysis, dermatofluoroscopy reached the highest sensitivity out of these 3 techniques. However, it reached the lowest specificity results. Optical coherence tomography also showed a balanced performance, and Raman spectroscopy showed higher specificity results than sensitivity. To conclude, we ranked all the investigated optical imaging modalities based on the UDEN index. The UDEN index is a summary measure of the diagnostic accuracy, with higher values indicating better performance. Also, this table summarizes the corresponding level of evidence for all the investigated modalities. Based on our statistics, reflectance confocal microscopy and dermoscopy combined with artificial intelligence reach the highest sensitivity, which can mean that these 2 devices could be the best for screening melanoma. Combining artificial intelligence with diagnostic methods like multispectral imaging and dermoscopy, it can significantly enhance the diagnostic accuracy of an imaging method, particularly in terms of sensitivity. Conventional methods like dermoscopy, teledermoscopy, and optical coherence tomography offered a balance of a high sensitivity and specificity, making them a reliable diagnostic tool. And Raman spectroscopy, multispectral imaging, and dermatofluoroscopy reached the lowest student index, which may indicate that these may be less effective compared to the top performers. The strengths of our study lie in its large sample size, encompassing a large number of patients and lesion numbers, and facilitating a comprehensive analysis of the non-invasive optical imaging techniques for the diagnosis of melanoma. The heterogeneity in the type of the studies and differences in testing strategy limited the systematic comparison of the diagnostic techniques. In conclusion, we can say that in melanoma diagnosis, both RCM and dermoscopy combined with artificial intelligence can serve as a second-step evaluation method following the initial screening of dermoscopy. We submitted our manuscript to the International Journal of Dermatology, and here you can see a photo for a published article. I would like to say a few words about our second project. Optically guided high-frequency ultrasound shows superior efficacy for preoperative estimation of Breslow thickness in comparison with multispectral imaging. This is a prospective diagnostic accuracy study. As I mentioned previously, melanoma is one of the most dangerous tumors, and early diagnosis and treatment can lead to a better survival for melanoma patients. Therefore, early staging is a crucial point of melanoma care. The stage of the melanoma is primarily established based on the Breslow thickness. However, it is unavailable at the initial clinical diagnosis. The accurate preoperative prediction of Breslow thickness could determine the exact surgical safety margin, the need for sentinel lymph node biopsy at the same time as primary surgery, and it could set out further imaging procedures such as PET-CT and MRI. So during our second project, we tried to measure preoperatively the Breslow thickness of melanoma with two portable non-invasive devices. First, we used the multispectral imaging device, which illuminates the skin with 4 sequential LED lights, one after another: blue, green, red, and infrared lights. The increasing wavelengths expose different structures of the skin, and this can give us information on different layers of the skin. The high-frequency ultrasound compared to the conventional ultrasound operates with a higher frequency, which provides a superior resolution for mapping of the skin surface, and it is also optically guided, which can aid in the operation of the ultrasound images. We aim to compare the diagnostic accuracy of optically guided high-frequency ultrasound and multispectral imaging for the preoperative prediction of Breslow thickness in melanoma. So this also led to our clinical question, which would be the more accurate device for this purpose. Here we used also a paired framework, and we enrolled 101 patients with histologically confirmed primary melanomas, and we investigated the patient with multispectral imaging and then with high-frequency ultrasound. We compared the results with the histological reference standard, and the diagnosis of interest was the overall diagnosis of Breslow thickness. Our hypothesis was that the diagnostic accuracy of optically guided high-frequency ultrasound is superior to multispectral imaging in the preoperative determination of Breslow thickness. And we proved our hypothesis because in every diagnostic accuracy measure, high-frequency ultrasound outperformed multispectral imaging, so it can be more effective and accurate in the diagnosis of Breslow thickness. We published our manuscript in Cancers, and here you can also see a print screen of our published article. And this is the summary of both of our projects. Both of our projects have been published. I'm currently working as a dermatology resident at the University of Debrecen, and you can see under that some of my achievements and conference presentations. And I would like to say goodbye with the quote of J.K. Rowling: "It is important to remember that we all have magic inside of us." And thank you for your kind attention.
Thank you very much. So your first study is actually the second study. The second is the first one.
Yes.
But because of the meta-analysis is expected to be the first one. So this, now, looking at this, your first study suggests that the specificity is actually rather low, I mean, in the international literature, I would say. And then your second study, I mean, with your own research, actually you showed that there is actually, in one of the methods, actually there is a very high level of both specificity and sensitivity. So can it be actually pushed through? I mean, well, on one side, that how does it come down to the clinical applications on the clinic? And the second one is that how to promote this. So therefore, this seems to be a better method than usually applied.
Mm-hmm. Thank you for your question. As you mentioned, I will go back to this slide. In our second study, both the sensitivity and specificity became high for the high-frequency ultrasound. And in the first meta-analysis, we didn't enroll the high-frequency ultrasound, so we didn't include articles with high-frequency ultrasound because we only included optical imaging techniques. And this is actually not an optical imaging technique, it just operates with an optical part. So it takes optical photos and it can aid the operation of the ultrasound images. So, and as you can see, multispectral imaging here in our second study, also the sensitivity and specificity became lower. And these two results, as we examined in our meta-analysis, they are correlated to each other, so they are similar. So actually, we expected this result. As the specificity performs for excluding benign lesions, in clinical practice it can be used for that purpose, to exclude all the benign lesions when we are examining, for example, in melanoma diagnosis.
What relates to this, that, I mean, in the first study you showed that with artificial intelligence and without. And actually this is a time-dependent phenomenon, as I understand. I mean that as the intelligence learn more and more, I mean, makes it better and better. So,
yes.
So how is that? Do you use here at the clinic actually artificial intelligence?
Yes, here in the Semmelweis University we use artificial intelligence for diagnosing different type of skin lesions, but our meta-analysis didn't include that.
But I mean, I'm just interested in the strategy and the concept. I mean, what happens next? Because these are really, I mean, very important, clinically extremely important issues. So therefore, I mean, both studies actually seem to be quite important to me, and therefore that's important then actually that is advertised in all ways. I mean, in the clinical side, and with colleagues, and with other centers, and also with actually the lawmakers, or the, I mean, that who does actually these standards of how to do this kind of diagnosis.
Yes, thank you for your comment.
Thank you for your presentation. Sorry for my broad question. I'm not familiar with your field, and my question is about the AI as well. Are these AI systems integrated into the devices that you're using, or do you have to operate it separately from these devices? Are these deep learning softwares, or are these just softwares that are already developed and you don't have to deal with teaching them what to see on the pictures?
Yeah, thank you for your question. Okay, so I would like to clear that we didn't use artificial intelligence, neither of our studies. The first one is the meta-analysis, and we included studies with artificial intelligence, but we aggregated all the studies with the artificial intelligence, so we didn't separate the data for deep learning or conventional neural network or something, so we just aggregated it in a whole that it works with dermoscopy picture and it combines with artificial intelligence. And in our second study, we didn't use artificial intelligence, and yeah.
Okay, so, thank you.
Thank you.
So, did you calculate also the predictive values?
Yes, in both of our projects, we calculated the positive and the negative predictive value. And in our first project, in the meta-analysis, as these predictive values depend on the prevalence, we also calculated with the statistician the highest prevalence rate where the melanoma appears in in all of the studies which are included in the meta-analysis, and it became a 30% rate of the prevalence. So we examined it on a 30% prevalence rate.
And how much were these? Around.
It's a good question. The whole table is in our article, and actually the positive predictive value correlated mainly with the sensitivity, so it was nearly the same, and the negative predictive value also was similar to the specificity.
And which measure is more important for you?
For us, because here we wanted to screen and we wanted to diagnose the melanoma, and as the second step evaluation method, the sensitivity was more important for us in this study than specificity.
Okay, thanks.
So I enjoyed those two presentations, really nicely done. On the meta-analysis, I just had a question for you. One of the challenges for this is the gold standard that you're comparing it to. So the gold standard is a diagnosis of melanoma, but that isn't a fixed thing, unfortunately. So when we look, the best data we have are in white Americans over the last 30 years. We've data from all around the world, Australia, really good data too. But what we see, especially in white Americans, is we see a really rapidly increasing incidence of melanoma diagnoses, but paradoxically, the number of melanoma deaths is going down. So there's a discordance there that there's some reasonable explanations for it. One, perhaps they're being caught earlier and treated. Another, perhaps advanced therapies are helping outcomes. That's another one. But part of it is overdiagnosis. And the estimates of overdiagnosis are, in the US, about 35 to 40,000 overdiagnoses of melanoma every year. So that makes your gold standard a floating one for all of these, because you're essentially trying to predict or lock into a floating gold standard. So with dermoscopy or AI or optical coherence, they're all going towards probably a histopathological overdiagnosis. Have you any concerns about that, or what are your thoughts about that?
Yeah, thank you for your question. So the best would be if the sensitivity and specificity both would be 100%. So, but that perfect diagnostic test doesn't exist. Actually, as Varga said, artificial intelligence will enhance and will increase and also will be more accurate will be more widely used in clinical practice. So as it develops, I think it would be the best device for reaching high sensitivity and specificity. Maybe that I would assume that.
Yeah, I think you're right on that. But I guess my point is what you compare it against, and if you're comparing it against a floating gold standard, that's a challenge for all of these studies. You have pathologists are overdiagnosing it for whatever reason, out of an abundance of caution, calling in situ lesions invasive lesions or marginal cases invasive, which they didn't do 10 or 20 years ago. It makes it very difficult to do predictive AI studies because you're always going to go back to the gold standard path. And there is a risk that it just drives over excisions and misuse of healthcare resource to some way that you end up cutting out more and more lesions that don't need to be cut out. There's always a risk of that with these in this space.
Yes, so yeah, histology can be a potential confounder for these results. I see your point. That's totally true.
And the ultrasound is interesting preoperatively. there's not many downsides to that, because if you take a little narrower margin, you can still go back. You know, you just hope that you don't have to do that as often as you would beforehand. So that's probably the measure of success there, is the number of repeat excisions, or the number of times that patient has to go back to the operating room for a second procedure. Do you have a sense of getting that kind of data with your predictive margin study?
Yes, actually the whole second study is about this one, predicting the Breslow thickness, and based on, yeah, so I think I get your point. The surgeons in the clinic didn't do the surgery based on our results, okay. So we just compared that after that. So, but it would be ideal that if we could say to the surgeon that, yeah, you can see here is a exact Breslow thickness, and you have to cut it with this exact surgical margin, but it didn't appear like this in our second project.
Yeah, so that's really, that kind of prospective study is really the way to validate this and say, you know, patients who you don't know their Breslow depth, you randomize half to what the surgeons normally do and a half to your technique, and then you look and see who had, on the one side, excessive margins, and the other side, inadequate margins, and how do those two groups compare, and are you optimizing? That's really where it's an expensive study to do, I guess, but it's the way to validate
it's a very good vision,
truly prospectively.
So you published these two papers. What's next?
We will see. A residency first, and after that we will see.
Mm-hmm. But do you still plan to continue this? I mean, I understand that you would like to close this down. So this is why we have these two papers. But in terms of future science, I mean, how do you think about that? I understand the residency, very, very important. That's not very easy to get a residency in dermatology, so that's very tough. And then you did a very good job here, so I hope that's a good entrance. But how do you think about your future research?
Yes, as I work at the clinical center in Debrecen, there are also some other projects and research activities. And actually, I've already had a discussion with Remenyik professornő, who was the former head of the department of the dermatology of Debrecen, and we discussed that she would like to buy a similar ultrasound device to the clinic at Debrecen, and she said we could be cooperatively work with the Semmelweis University, maybe on a higher patient number and melanoma cases, so that would be the future plans for me. Continuing this diagnostic study.
Yeah, that's very good to hear, because this is why we are here, actually. I mean, to develop projects and then to develop fellows, and then they continue, actually, in a high level of clinical work. Yes. Thank you very much.